Alright, so this is case number 5, a left lower extremity amputation with diabetes and peripheral vascular disease. Our patient is Mary Gaines, and this is done by Ashley, Jenn, Alex, and Eve. So our patient is a 65-year-old female who is a widow. Her current onset of history, she dropped a glass of water on the floor, and then the next day she stepped on some of the remaining broken glass. The cup became infected, and the patient was admitted to the hospital for IV antibiotic treatment. Gangrene developed, and she was seen for a vascular surgery consult. Due to her 5-year history of diabetes and her 10-year history of severe PVD, she had a below-the-knee amputation of her left lower extremity. The patient was discharged to home with assistance of family, friends, and a home health aide who she hired on privately. Her medical history, she has diabetes, mild obesity, hypertension, mild angina for 10 years, PVD for 10 years, and with a history of intermittent claudication when walking distances greater than a quarter mile, and she also smokes 1 to 1.5 packs per day for the past 50 years. She's on a bunch of medications like tenormin, nitroglycerin tabs as needed, Darvin for pain, and Coumadin, and NPH regular and ultralentin insulin. She lives alone in a first-floor garden-style condominium. She is independent her prior level of function, she was independent in all ADLs, including driving and community mobility at an ambulatory level and walking. She is a retired registered nurse, and she enjoys sewing, knitting, playing with her 2 grandchildren, playing bridge with her friends, and attending her weekly support group for widows and widowers. So this is the ICF model. So her health condition, she has diabetes, severe PVD, mild obesity, hypertension, angina, and mild intermittent claudication. Her body structure and function, she has a left below knee amputation. She has moderately impaired sensation to light touch pain and temperature in her right distal lower extremity, and minimal deficits noted in the residual limb. She has phantom sensations. Her straight leg raise on the left is decreased compared to her right. Her ankle range of motion and strength below the knee on the left is not applicable. She has moderate edema in the residual limb, and her left lower extremity manual muscle testing is fair plus to fair minus, and her left knee flexion extension is limited by pain. So some activities, she can do ambulation using a standard walker of 20 feet, no complaints of angina or heart rate and blood pressure rising above doctor prescribed guidelines which are listed. And she can also do bed mobility and transfers independently, but they are slower. Her limitations, she cannot perform ADLs independently. She needs assistance. She cannot ambulate more than 20 feet without a standard walker. She cannot drive. She has poor balance, and she's unable to ascend and descend stairs. What she can participate in is sewing, knitting, and playing bridge in her weekly support groups as long as she finds someone to drive her. But she cannot get around in the community, play with her 2 grandchildren, cannot grocery shop alone or do laundry or clean on her own. So some personal factors, some positive ones. She's not on medication for depression any longer, and she's eager to getting back to living independently. Negative personal factors, she has pain, fear, angina, and her heart rate and blood pressure rise with exercise, and she could become depressed easily again because of her husband's death. Some positive environmental factors, she does go to a weekly support group. She has an appointment to learn how to use her prosthetic, and she uses a standard walker for ambulation. Negative, she can't drive, she cannot ambulate in the community. She does not have a prosthetic as of yet. She lives alone, and she could have medication side effects as well. So this is a list of her problems, like mentioned before. A couple of the ones were already mentioned, but she does have sensation problems, balance problems when she's standing, but when she's sitting, she's fine. She has mild constant pain in the residual limb and with range of motion and active movement of the limb. Her staples are intact on the residual limb, but there is some moderate edema and a little bit of drainage. And with her mobility, she can do bed mobility and transfers independently, but gait, she can ambulate 20 feet with a standard walker without complaints, and then moderate complaints of pain with ambulation. She is fearful of trying to use a roller walker because of it getting away from her, and she's unable to use stairs.
So for the plan of care, the patient will be educated about the negative side effects of smoking, how to wrap the residual limb, and how to don and doff the prosthesis, and how to do scar mobilization. Patient will perform exercises to improve the strength and range of motion so she can return to having the ability to ambulate community distances, transfer with her prosthesis, return to driving, be independent in performing daily routines and tasks, and independent in home management. For the interventions, the PT will show the techniques of donning and doffing the prosthesis to promote prosthetic comfort and independence, and how to wrap the residual limb, perform scar mobilization techniques. So this will improve the shape and decrease adhesions. The patient will perform bridges to increase strength for balance with standing. The patient will perform weighted hip exercises that increase strength for prosthesis mobility, and this will be progressed by performing separating exercises for mobility. Continuing with intervention, the patient will also do ankle pumps and PNF techniques to increase the lower extremity strength and maintain the range of motion, promote vascular sufficiency, and this can be progressed to having them stand on a ledge and doing heel raises. The patient will ambulate with prosthesis in the parallel bar to increase self-efficacy and independence while ambulating, and this will also promote vascular sufficiency and cardiovascular endurance. It will also promote a normal gait, and this can be progressed by having the patient perform the activities outside the parallel bars or on uneven surfaces.
Okay, so there's some additional factors that have to be considered, such as comorbidities, changes in the different body systems, the patient's rehab potential, psychological variables, and other variables that will be related to the outcomes and the different types of interventions. Some of the comorbidities that we've already spoke about include a 50-year history of diabetes, 10 years with severe PVD, including mild intermittent claudication, hypertension, mild angina for the last 10 years, mild obesity, a 50-year history of smoking, and some depression. Overall, there are several changes and declines in functioning in all of the different systems of the body, but these are the main ones that will affect her. For the nervous system, there's an increase in vasopressin with age, and that will cause implications for the blood pressure and renal functioning. This will cause the blood pressure to stay elevated, and she already has hypertension. She already has decreased sensation, most likely due from her diabetes for the last 50 years and smoking, but this will be exaggerated with decreases in sensation from aging. Her gait, balance, and posture will also have changes with reduced reaction time, slower movements, and increased sway. And learning also becomes more difficult as we age. There are a lot of changes with the cardiovascular system. These are some of them, but there are several more, especially because of her history of hypertension, diabetes, PVD, angina, etc. Most likely, her arteries are going to be less compliant, which will make it more difficult to pump blood through the body. Her valves are probably stiffer and may have venous insufficiency due to the PVD. Changes in baroreceptor sensitivity will change heart rate and blood pressure. And there will be more adipose in her arteries, which increases her risk of CAD and other cardiac conditions. hypertrophy of the ventricles and increased cardiac stress from afterload will also cause more problems with hypertension. And peripheral vascular resistance is most likely up in her arteries, so that will increase her systolic blood pressure more. In the pulmonary system, she'll have several changes due to her 50-year history of smoking. She most likely has calcification and stiffening of her thorax, which comes with age, wasting of muscles, and decreased oxygen saturation, especially to the heart from decreased arterials to the heart tissue. There's also reduced area for gas exchange, increased dead space, reduced elasticity, and reduced vital capacity, among several other decreases in many pulmonary rates and capacities. Incontinence can be an issue with the genitourinary system because it may increase fall risk if she's trying to rush to the bathroom, and it can also change the condition of the skin. With aging and cardiopulmonary conditions, there's also skin changes, including thinning and drying of the skin, which makes it easier to irritate and easier to get an infection. You also have to be careful with the skin because it's easier to abrade. With the musculoskeletal system, there'll be thinning and less congruent cartilage, a higher chance of osteoporosis, osteoarthritis, and decreased bone density, especially if she's decreased weight bearing from having a prosthesis. She will have slower movements and reduced cross-sectional area of her muscles with age, which will also be related to her balance issues.
We have decided that her rehabilitation potential is fair, and we've listed some of the psychosocial variables. The negative ones include a major depression and a fear of using a rolling walker, which she feels is going to get away from her. And the positive variables include having a large number of friends, frequent visits from her family, and assistance of family, friends, and a home health aide. This is a list of some of the factors that can influence outcomes. Favorable ones, including the social support, previous independence with her ADLs, and her desire to return to community ambulation. And some of the unfavorable ones include depression, the comorbidities, angina, obesity, smoking, impaired sensations, edema, medications, and aging changes. We've compared some compensatory and restorative interventions. The compensatory ones include bridging exercises, ankle pumps, PNF patterns, weighted hip exercises, and learning to use her prosthesis. The restorative interventions would include bridging exercises, ankle pumps, PNF patterns, and then any additional strengthening exercises. So we went through the evidence, and the evidence we found were for a foot care program, a strength asymmetry, a cycle exercise test, and audio biofeedback. So the study I did by Ashley, a foot care program for diabetic unilateral lower limb amputees. The purpose was to assess the efficacy of a specialist foot care program designed to prevent a second amputation and to assess PVD and peripheral neuropathy in diabetic unilateral lower limb amputees. So there were some issues of external validity, but some positive issues were that the researchers were able to follow the group of patients over 1 and 2 year periods in order to gain a better understanding of their education and knowledge, and their risk for another amputation. But a negative issue is that it was a small sample size, included in both groups that were compared, and the demographic area where the patients were tested, it was not easily able to use in other demographic areas. Some issues of internal validity, some positive ones. The study was compared to another group of patients who were also assessed in the same way and who also received the same prosthetic care, just at an earlier time, but for the same time period, and it was easier to make comparisons and see differences. A negative was that the patient's social categories were estimated based on the Registrar General's categories, where whoever was testing them kind of would ask them a question and try and figure out, based on the certain categories, what category they belonged in. So it was whatever one they were closely fitted to instead of what really fit them. So the results of this study showed that an establishment of a specialist foot care program made no impact on the contralateral limb amputation compared with a matched patients without the program over a 2-year outcome period for each patient. So clinical use, it was shown that prevention foot care programs for diabetic unilateral amputees should place greater emphasis on peripheral vascular assessment to identify the patient's risk and on the development of intervention strategies for amputations. And it also showed that PVD is more closely associated with diabetic bilateral amputation than neuropathy or level of foot care knowledge.
I, Alex, did my presentation on strength asymmetry and osteoarthritis risk in a unilateral transtibial amputation and how that affects gait. This article is an experiment of a cause and effect that exists when a person with unilateral transtibial amputations, and if they have an increased risk of developing osteoarthritis on their other limb. The experiment hypothesis was formulated because between side strength differences were observed in individuals, and it was thought that the individual would put less weight on the limb with the prosthesis and therefore would cause the gait to be asymmetrical because of the range of motion and the way that the person bared weight on their limb. Here are some of the external validity strengths and weaknesses. And then here are some of the issues with the internal validity. And then for the results, in summary, the results showed that transtibial amputation patients are indeed more asymmetrical in strength and osteoarthritis risk variables than their able-bodied counterparts, and strength asymmetries of the knee extensors and flexors are related to ground reaction forces and joint moment loading rates in transtibial amputation gait. Measuring strength asymmetry may therefore be an important way to assess problematic gait patterns in transtibial amputations in order to reduce the risk of osteoarthritis in the intact limb. Future studies could look to see if muscle strength and strength symmetries following a training protocol have been shown to improve the functional ability in transtibial amputations. They should investigate rather if strengthening protocols are effective at reducing osteoarthritis risk variables on the intact limb.
Okay, my research was on a graded one-leg cycle exercise test for determining peak aerobic capacity in older adults with lower limb amputation. The main purpose of the study was to test and describe a discontinuous graded one-leg peak exercise test on a cycle to determine whether it is feasible and provides a valid assessment of the peak aerobic capacity in older people walking with a unilateral lower limb prosthesis. It was a quasi-experimental case control study with 36 people with unilateral lower limb prosthesis and a control group with 21 able-bodied participants around the same age. The relevance of this study was that graded exercise tests are often shown to help predict walking ability in patients with lower limb amputations, and walking is an important ADL. Relearning to walk and ambulating with a prosthesis has increased energy costs, so patients need to be able to work on their strength and ability to walk with their prosthesis. Treadmill tests are not very suitable for patients with amputations, and exercise tests are important for making safe, individualized exercise programs. The important results of this study were that both the control group and the unilateral lower limb amputation group had stressed the cardiovascular system to a similar extent. They showed that the discontinuous cycle exercise test was feasible and that it provides a valid assessment for aerobic capacity and exercise tolerance in this population. Some of the advantages to the design of the test were that it was easy to administer because it uses simple standard equipment that is fairly low cost and easy access. It's also a very safe protocol with accurate blood pressure readings and clear EKG tracings. Because it's discontinuous, they took blood pressure readings during the breaks of the test so that it was more clear, and the EKG readings were clear because they did not use upper extremities. People with amputations likely have comorbidities and are at an increased risk for CAD, so monitoring these things can help catch signs of the disease or changes in their disease state. These are some of the strengths and weaknesses of the external validity with the sampling. One big one was that they had a significant number of people and that both groups had similar age. One of the big weaknesses is it can only be generalized to patients able to ambulate with their prosthesis already, so this wouldn't apply yet to our patient. Some of the strengths of internal validity include the use of a control group, which is important, and the control group did both a single and double leg cycle test to compare both modes, and they also did the discontinuous test in both groups. A minimal upper extremity movement made for clear EKG readings, and the blood pressure and EKG monitoring increases the safety of this test. Limitations to the study were that the participants with the lower limb amputations were fairly healthy and active, and all people with lower limb amputations are not necessarily healthy and active. All of the participants also had their amputations for over a year, so it can only be generalized to those group of people. It can't be generalized to recent amputees, less active amputees, or people who are not accustomed to this type of exercise. Potential future research would be to see if this test is applicable to people with more recent amputations who are less active or who have less health issues or more health issues. They should also do studies to look at the reproducibility of this test for sensitivity and the ability to detect change after an exercise program. They could also explore other modalities combining upper and lower extremity movements.
My research was the quantitative analysis of the effects of audio biofeedback on weight-bearing characteristics of persons with transtibial amputation during early prosthetic ambulation. The purpose of the study was to determine if audio biofeedback could help patients with transtibial amputations to more accurately follow weight-bearing restrictions. So the goal is to improve healing time of transtibial amputations by preventing some of the excess stress placed on the residual limb early in ambulation. This is a list of the external validity. Some of the strengths were that it accounts for comorbidities in the population, and both men and women were of a wide age range. Weaknesses were that it was a small number of participants, there were only 6, and it can only be generalized to patients that are able to ambulate with their prosthesis and have accurate hearing. This is a list of the internal validity. Strengths were the use of a control group, multiple tests and dates to allow for day-to-day variations and a learning curve, and precise measurements of weight bearing throughout the entire gait cycle. And weaknesses were that the control and experimental group had to be aware of what group they were in. Individual gait deviations couldn't really be taken into account, and again, it requires the patient to have accurate hearing. The results of the study were that the average peak load of the gait cycle was a lot closer to the prescribed weight in the experimental group, and there was a decreased variance in weight-bearing stress in that group. Clinically, that means that we can reduce the stress on the residual limb and improve healing. For future research, they could look into what type of audio biofeedback should be used as far as like a sound tone and duration.
I would like to see a longer length of study to determine the effect of like a learning curve, see if it improves over time. Long-term effects on ambulation and overall healing time of the residual limb, and see the effects of sensation loss or any other sensory deficits on this program. All right, now we've got some take-home points. Using audio biofeedback can improve patient adherence to weight-bearing restrictions. Cycle exercise tests are valid tests for measuring aerobic capacity for patients with lower limb amputations. Strength measurements can be used to assess problematic gait patterns in patients with transtibial amputations. Peripheral vascular assessment should be used to identify at-risk patients and to help develop intervention strategies for patients with amputations. Smoking, PVD, and diabetes will increase a person's ability to heal from an amputation. Proper alignment and education of prosthetics will help the patient to become more independent in ambulation and ADLs. Yeah, we're going to pretend that says ambulation. And these are our references.
That's all, folks. Woo!